Good afternoon and welcome to Ask the Docs, a Fertility Institute of Hawaii live stream. November is Men's Health Awareness Month and our topic is optimizing male fertility. Thank you for joining us today. We have a lot of great info to share. My name is Dr. Carmone. I'm here with Dr. Goulet and we have Dr. Fraterelli on as well.
Hello.
All right, so why don't we just start out by talking about male infertility in general. So, Dr. Fraterelli, what kind of issues can males have?
Well, there's obviously men. When you need to have a baby, you need sperm, eggs, and uterus. The three ingredients I always tell people. And so for men, you got to have the sperm. And so there can be sperm production issues. There can be sperm motility issues. So anything that abnormal with the semen analysis, which we'll discuss later. But there also can be functional issues, right? There can be erectile dysfunction. Some men may have had traumatic injuries that may have affected the spinal cord, and so there are other reasons why men may have ejaculatory issues. One common thing that we see is retrograde ejaculation. And that can be associated with medical conditions like diabetes, for instance. So, and what happens with that is the male will have the sensation of ejaculation, but without any ejaculate, being seen. And so, what happens at that point? We'll get a urine sample after the ejaculation, and we can make the diagnosis that way. There can also just be issues with the testicle. There can be blockage in the testicle that will lead to a man not having sperm or having sperm issues.
Yeah, and I think ASRM mentions that up to 40% of infertility is either completely attributable or partially attributable to a male factor. So it's a pretty significant proportion of infertile couples actually do have a male factor issue. So Dr. Goulet, what is the evaluation that we typically do?
Right. Men typically have it a little bit easier compared to our female patients. They only have the first preliminary test, which is that semen analysis. There are only certain labs that can perform a semen analysis because not everybody has the technicians that are trained in performing this. So you can't just go to any LabCorp and have a semen analysis done. But at an appropriate lab, we would order a semen analysis. We do that here in-house, and we get information on that semen analysis that tells us about the number of sperm that are present, the volume of the ejaculate, how many of the sperm are moving, and then the shape of the sperm. And so all of these things combined can tell us, is there an absolute male factor, for example, if we don't see any sperm, or is there a subfertility factor? For example, we see lower motility, less moving sperm, less alive sperm than we would normally expect to see. Now, oftentimes, even when there are subfertility factors on the semen analysis, there are things that we can do from a female treatment perspective to help that sperm and that egg fertilize without us having to go through extensive workup and evaluation of the male patient. However, when the semen analysis comes back concerning either for very low counts or very low morphology, at that point, we would recommend further workup with a urologist to get hormone levels tested and to get a physical evaluation and perhaps an ultrasound of the scrotum to look for things that could be contributing to that abnormal semen analysis, and that may be correctable.
Typically, there are a number of different things that can contribute to a male factor. And so those can be divided into heritable forms, things that you might have inherited from family members. And those could cause both obstructive issues, so blockages, as well as non-obstructive issues and low sperm count or no sperm. There's also environmental factors, right, or anatomic factors. And so it's important to kind of figure out what's what. And actually the other category, which is the most common one, right, is just it's unknown. So sometimes and oftentimes males have a fertility issue and we don't exactly know why. So in terms of the heritable forms, there are some genetic abnormalities that can occur. They're either inherited from family members or they can be sort of spontaneous issues. So one of them would be, for example, karyotype abnormality. Okay, karyotype gives us the information about how many chromosomes we actually have. And so sometimes if there's an issue with the number of chromosomes, certain health issues can occur. So for example, having 3 chromosome 21s is the cause of Down syndrome. There are some other karyotype abnormalities which may cause male infertility. Klinefelter's is one of them. That's where a man has 2 X chromosomes as well as a Y chromosome. And so he may be completely normal and may not ever realize this and be a normal male up until he tries to conceive. And when we do a semen analysis, we see that he does not have, that he has an extra X that he doesn't have any sperm. Then when we test the karyotype, we'll see that extra X. Similarly, there's something else called a Y chromosome microdeletion, where kind of part of the Y chromosome can be deleted, and this can cause issues with sperm. The other heritable issue which can occur would be cystic fibrosis. So being a cystic fibrosis carrier sometimes can cause issues with the vas deferens that kind of carry the sperm into the ejaculate. And so when you're missing that, there won't be any sperm in the ejaculate. This is more of an obstruction issue, but there will be good sperm production. And so there's kind of a number of different things that we can test for depending on what we see.
And you brought up a good issue with obstruction, because sometimes that obstruction is elective and intended. For example, when a man has undergone a vasectomy and later on chooses to have children after the vasectomy, there are ways we can work around the vasectomy. One way would be to refer you back to the urologist to have the vasectomy reversed. There's pros and cons with that compared to the other alternative, which would be surgically extracting the sperm and using that with IVF. And so there are ways that we can work around an intentional obstruction if that happens to be the male fertility factor.
A couple things to add, just to first to Dr. Goulet's comment about semen analysis. Certainly, only certain places can do semen analysis. However, recently there has really been a revolution in people being able to do it at home. You can do mail-in semen analysis. There's an app on your phone that you have to get the right apparatus, but you can do it. You can use it that way. Although that's mainly that app right now is mainly for clinical use, but because it's fairly expensive, so I doubt anyone's going to just purchase that for themselves to do their own semen analysis. But there are ways that you can do semen analysis without leaving your home. You may not get the best answer. There's certain parameters. If it's a normal semen analysis, they probably can tell you that. But if it's a really low count, they might count it as, it might say that you have azoospermia or that you have no sperm. And so on the edges, where there's too much or too little of something, then those things don't work as well. But in general, they are being utilized utilized more and more. And then about the evaluation for the male, certainly the first thing we always like to do is send them to the urologist if there's an abnormal semen analysis. There is a certain percentage of those men who may have testicular cancer, and they're more likely to have testicular cancer if you have a significant abnormal semen analysis than someone who has a normal semen analysis. Doesn't mean you have cancer, but you just have a higher risk. And so because we may see somebody who has really low count and a really low motility, those are men who are at a higher risk, so they go to the urologist for an evaluation and testicular exam. And some things that urologists may find include like a varicocele, which is very common. And a lot of men come in knowing they have a varicocele, which is basically just a dilation of the veins in the testicle. And that in some areas may be associated with fertility, and the urologist may have a treatment that they can do, which is surgical. It doesn't help most patients with the varicocele, but there are certain ones that certain select individuals where it might be beneficial.
Yeah. To go off of that, the varicocele itself, is sort of graded, and if it's very severe, then that may be something that is more likely to improve fertility if it's fixed. Other causes of infertility are more difficult to kind of nail down. So the environmental factors are thought to be contributing to what's called isolated teratospermia, which is where the only issue is the shape of the sperm. And this is extremely common. I think a majority of our patients suffer from this, and worldwide, actually, morphology appears to be declining. And so with isolated teratospermia, unless the teratospermia is very severe, we don't really recommend any special kind of treatment for the male. There may be some antioxidants that have been shown to improve semen parameters, but have not necessarily been associated with improvements in live birth. So questionable, how much those really help, but that's something to consider when you have kind of some mild sperm abnormalities as well.
That's also very common with the male sperm literature, in that there are a lot of things that may improve the number of sperm or motility to a significant degree, but significant is relative because you're talking about millions, right? So but it may improve the semen analysis, but most of the literature doesn't show benefit of outcomes, pregnancy outcomes, and it might just be a numbers issue or the methodology of the studies.
One thing I caution my patients, for men who are trying to do things like take vitamins or make positive lifestyle changes, that we're not going to see these improvements in the semen analysis overnight. It takes 90 days for a sperm to be made. And so it's going to take a minimum of 3 months, but probably more optimally 6 months to a year until we see optimal improvement in sperm. And most people don't want to wait a full year to see how good can we get the sperm. Other things that I get questions about are, what about, lifestyle choices? Does alcohol affect the sperm? And we do think that moderate to heavy drinking can reduce the semen analysis parameters. Caffeine we know to be fairly safe. But of course, if you ask any doctor regarding tobacco or nicotine use, we're going to advise you to stay away from that for your health and for the health of your sperm.
Excessive caffeine intake isn't good though. So three cups or more, which I don't find to be very excessive, to be honest with you. But that's what
a cup of coffee.
So, but a cup or two, actually for men, a cup or two should be fine.
Everything in moderation.
Right.
Yes.
Obesity. I don't know if you mentioned that, but obesity is something that seems to increase sperm DNA damage. And so improving that, over time, you may see improvements in sperm quality. Other than the semen analysis, so like Dr. Goulet said, men have it pretty easy because usually it's just sort of the semen analysis, and if that's okay, then we move on, and women have lots of tests, right? But if there's an issue with the semen analysis, then we may need to do some additional testing for the male. So that might include blood work, and that's going to look at the hormone levels. That can tell us if there is an issue with the thyroid, prolactin. Sometimes that can impact sperm quality. It'll tell us if the testosterone levels are off, or if the hormones which signal the testicles to produce sperm are off, because that can help us determine if some medication actually may be helpful. And then, as I mentioned before, we can also look at some of the genetic issues depending on what the problem is. So if a male has no sperm, we may opt to do the karyotype to determine if there is an issue there. We may opt to do the Y chromosome microdeletion testing. But that would only be if somebody has a pretty severe male factor. We wouldn't necessarily look at genetic causes for someone who has a more mild to moderate form of a male factor. And then lastly, there's sperm DNA fragmentation analysis, which there are a few different companies that are doing that now. And that's interesting because there isn't a great treatment available yet. So there are some treatments, but questionable how much those are helpful at this time. And so physicians in general, we don't really like to do tests when we can't really fix the problem. And so it's not routinely offered. But for example, if somebody has a very severe sperm DNA fragmentation index, or they have pretty bad sort of sperm DNA fragmentation in their sperm, then we could even consider donor sperm, depending on what their potential fertility looks like, what their cycle, if they did IVF, what their IVF cycles look like, or if they have a history of recurrent pregnancy loss, that may be contributing to that. And then there's some kind of newer, more controversial treatments. So, for example, doing testicular sperm extraction, which is typically reserved for people who have, an obstruction, or people who have very, very, very few sperm. The thought is that if we extract sperm at the time before they kind of go through everything they need to go through prior to ejaculation, then we may be getting sperm that's kind of less fragmented. And so that is something that some centers are currently considering with kind of a severe sperm DNA fragmentation.
The newest American Urological Association actually now recommends that sperm DNA fragmentation for recurrent pregnancy loss. So if there's been miscarriages that have happened that have been unexplained, certainly seeing a fertility doctor, having both individuals worked up and seeing what tests are appropriate, could be a karyotype for both individuals, and perhaps now even that sperm DNA fragmentation testing as well.
And I think that is important to realize that really only gives you a diagnosis or a thought about that it might be related to the sperm. The only treatment is using different sperm potentially, or like Dr. Carmon said, there's some other therapies that have been tried, but with minimal success. Doing a TESE. When we try to do IVF, we try to get the freshest sperm possible. So we have men ejaculate, daily for a few days before the IVF cycle to get the freshest sperm possible. There's studies showing that you lowered fragmentation, DNA fragmentation, if you're getting the freshest sperm. So we'll do that. But there really is limited ability to treat those guys other than using donor sperm potentially.
Did we mention smoking? Smoking is
everything in moderation, but except for smoking.
Smoking is really good for sperm. No, I'm just kidding. It's not good at all for sperm. It's terrible.
Right, and that includes anything.
So it's not everything in moderation.
Not
it's
just
most
tobacco.
things in moderation.
Yeah, tobacco, no smoking. There are some places where some centers will actually test for nicotine in the urine of males and females, and actually not offer IVF in those cases, because at least the insurance companies are stopping them from getting IVF coverage because of the lower success rates in men and women who smoke.
So there was a very wise physician that I once heard that gave a patient advice. And the advice was that for fertility patients, male or female, if it's bad for your health and bad for your heart, it's probably bad for fertility.
Is that me? Didn't I say that?
That was
me,
you.
right? That was me. I said that. Yeah.
Yes.
Right. Yeah. So there are no surprises here. There's tons of literature, all types of associations looking at what's affecting both male and female fertility, really. And there just aren't any surprise. There's no studies that show that bacon is really good for sperm. It's just everything is exactly what you would expect. And so, if you follow, I
But
actually,
life sucks.
yeah,
It really does. You can't have fun.
right.
You enjoy yourself.
I usually, and most of the kind of current literature we're looking at nutrition is looking at dietary patterns, because it's very difficult to study, but it's a smarter way to go. And so when people are asking what type of diet is best, is it keto? Is it this? Is it that? Is it the Atkins diet? I mean, Dr. Atkins died of a heart attack.
Yeah.
And maybe he had no sperm. I don't even know. It's hard to say, hard to know. But I would suggest something more along the lines of the Mediterranean diet, which is just very well balanced. Okay, so low carb, but not no carb. Lean meats, mostly plants, but lean meats, fish, lots of leafy greens. If you're going to drink alcohol, red wine, right, has a lot of the tannins in it, the good stuff, a lot of the antioxidants. Use of olive oil, light salad dressings like balsamic vinaigrette. Those are all the things that I feel like all you guys know already. And those are the things that have been associated with improved everything, including good fertility. Yep. Don't take testosterone. So
Yes.
yeah, we do see a lot of male
Make your own testosterone. Don't
your own
take it.
testosterone. So this is something that it's kind of confusing until you really study it. But because people think, well, testosterone is good for your sperm or whatever. So what ends up happening is, because of this kind of complex feedback loop, if you take in testosterone, then your brain kind of feels that, and they say, oh, listen, this guy's got enough testosterone. They're going to shut down the brain hormones, which signal to the testicles to produce sperm and produce testosterone, right? Because they say, oh, we got enough. We can stop, right? Because the brain is not sensing how much sperm you have. The brain is sensing how much testosterone you have, which oftentimes will go together, right? And so if you take testosterone, it's going to shut it down. Now, there are some men who will try various things, and some physicians who are prescribing testosterone who try kind of different ways of getting testosterone levels up, and also trying to drive sperm production. So people will be on things like testosterone plus HCG plus Clomid, sort of various mixes or cocktails, so to speak, to try and keep the sperm levels up despite taking testosterone. But at least from what I see from my patients, really various levels of success. I do see a lot of patients who come in, I don't know if you guys who are like, well, my doctor says that I'm supposed to have sperm, and I'm kind of like, well, you don't, so I don't know. And it's not to be rude or anything like that, but it really, there's no question that testosterone use is going to impact your sperm production. Now, for some men may be more sensitive to it than others. But if you're trying to conceive, then stopping or weaning off the testosterone is probably the best thing you can do. There are some other medications that may improve testosterone levels. So for men who are very dependent on testosterone, what we might consider doing is stopping the testosterone and starting medications like Clomid or HCG, which again will drive your own testosterone production and also drive your own sperm production. And so it's not you may not feel quite as good as you do when you're taking weekly testosterone, but you'll just be more likely to conceive.
And on that note, for my patients who say, oh, well, I was on it for, 3 years, I'll just stop and it should be fine. Unfortunately, what we see for individuals who have been on testosterones for a long time is that some of that sperm making capacity can be permanently reduced. And so we may not be able to rebound back to baseline sperm production that it was before you had started testosterone. So if you haven't had children yet, if you are thinking of having children, Stay off the testosterone until you are done with your family building, because that can produce a permanent, sometimes severe reduction in the sperm making capacity that may not be recoverable.
And for those who just need the testosterone, you can preserve your fertility by giving a couple of samples and freezing your sperm as an option, if that's something you just really can't do without.
Yeah, that's what I was going to bring up. That freezing sperm is especially compared to freezing eggs, it's a relatively cheap and easy thing to do.
Easier.
If you live in Hawaii, you can freeze with us, or and you can store here, or we can ship sperm to long-term storage facilities where it's even less expensive.
You can't freeze your sperm at home. That's not something you can do.
Oh, no, don't freeze the sperm at home. Yeah,
Doesn't
it's
work that way.
not in the freezer. I mean, you can, but it's not going to work.
It's not gonna
Probably
work.
not going to work later when you go to thaw it.
You're still gonna have no sperm if you do it that way.
Right. Yeah. And that's, like I said, much easier than freezing eggs. So the other thing too that we kind of briefly mentioned was there is a significant male factor that's due to ejaculatory dysfunction or erectile dysfunction, just sexual dysfunction in general. And that is usually, unfortunately, made worse by infertility and not better. There's a lot of literature about this where, people who are kind of feel like they're forced to have sex kind of have a harder time than if they're doing it for fun. And there are a number of treatments for that. I mean, obviously, you guys probably have heard of medical therapies, things like Viagra for erectile dysfunction. But probably even better than that is intrauterine insemination. So intrauterine insemination, you can come in, give a sample. You can give a sample at home, bring it in, right? And then we can basically, it's the turkey baster method, right? We take the sperm concentrated, put it directly into the uterus. And so then it kind of takes that stress out of sex, and you can do it at your leisure. IUI, or intrauterine insemination, is also a treatment for, the main use of it, right, is for kind of a male factor infertility, mild to moderate male factor infertility, where the count is a little bit low, or there's some kind of lower markers there. And what we do is we're sort of concentrating all the sperm and putting it all in the uterus so that there's just a much higher load of sperm that gets to where it needs to go. So that's kind of one of the major therapies. The other therapies are, in vitro fertilization with ICSI. ICSI is where we actually take the sperm and inject it directly into the egg. So even with very, very few sperm, as long as there is sort of some live sperm there, we can usually get things done with ICSI. And then there are the medical therapies, and that's going to vary based on what the problem is. If there is an issue with the hormones that are signaling the testicles to produce sperm, then we may be able to give some medication to rev that up. If there is an issue with an obstruction, so what I mentioned before, either the absent vas deferens or an anatomical obstruction for another reason, then we can typically kind of get sperm above the level of the obstruction. Or if somebody has a history of vasectomy, right, same thing. Or if somebody has no sperm in the ejaculate, but some sperm production somewhere, we can do what's called a TESI, which is the testicular sperm extraction. And the urologist can kind of search for sperm either with or without a microscope. If they use a microscope, that's a micro-TESI. And then if any sperm is found, we can then use that sperm for ICSI, for in vitro fertilization. Unfortunately, we can't use that sperm for insemination or natural conception. We still have to use that along with ICSI. Yeah. I don't know. Any other thoughts?
No.
Right. Yeah. There are some medications as well, which aren't great for sperm. So, but don't just go ahead and stop medications. There's retrograde ejaculation is one of the things Dr. Frederelli briefly mention, there are some medications that famously can contribute, some medications for prostate health, as well as certain blood pressure medications, which are less common, but those can cause what's called retrograde ejaculation, where a man will feel the sensation of ejaculation, but nothing will come out, right? And then oftentimes the medication can either be stopped, or we can get sperm from the urine. And then we'd have to do treatment with that as well.
And associated with that, I think it's sometimes confusing in that, you feel like you have an ejaculation, but there's no sperm, but nothing comes out. And the other thing that men are confused by, even more so, is they're having an ejaculation, they're seeing ejaculate, but then there's no sperm, right? And so the ejaculate is not sperm. The sperm is, just a 1% or less of the volume of the ejaculate, and basically the sperm is coming from a different duct than all the other fluids are coming from, and so sometimes that duct can just be blocked, and so there might be lots of sperm, good sperm, it's just that duct is blocked, or it might be that there, as Dr. Carmon said, the lack of a vas deferens, and so then the sperm's not able to come out with the ejaculate as well. So there are different things that we need to look at when couples are having fertility issues, and oftentimes the male will say, "Oh, everything's working fine. I don't think I need an evaluation," but unless you look under a microscope, you really don't know.
Right. There are also the last thing that I think we didn't mention is there can be some things which can actually damage the testicular tissue, cause scarring there, and that can actually cause male factor issues. So, history of certain viruses, which people hopefully won't come back, but things like CO that famously used to affect the testicular function, as well as just injuries. Testicular torsion, where the testicles twist on themselves, the blood supply can be cut off. You would know if you had that. It probably hurts a lot. Then you may need a surgical intervention to kind of untwist them. That can cause issues, or any kind of injury, certain types of surgeries. So there are things which can. So getting a good history, right, from our male patients is important, because there may be some things in the background that may be contributing. So, well, I think we've kind of covered as much as we can. Not being urologists here, we're just REIs, but we do see plenty of male factor in our practices. And definitely, whether you have kind of a known male factor or not, doing that semen analysis right off the bat, along with the female partner's workup, is important. A lot of times men are like, well, I'll let you, women do this too, we all do this, but a lot of times men are kind of like, well, I'll let you do your workup first, and then we'll see, like, if you don't have any issues, then I'll, because many times it's male and female issues that are contributing. And then even if it's mainly a female issue, we need to know what's going on with the male part of things to figure out what type of treatment we need to do. So, well, thank you so much for joining us. This is Ask the Docs, a Fertility Institute of Hawaii live stream. If you have any additional questions, please feel free to write in. We can respond later. If you would like to speak more with one of us, you can schedule a consultation. And we look forward to meeting you soon.
Aloha.
Bye, guys.